This is Andrew Kramer, Urology Associates at Cape Cod, and I'm here to take care of a great guy, military veteran, recovered from a lot of issues there, comes in having had an implant in the past. He's got a history of a fat graft, but on this occasion, he has something new, which is there's a ballooning out, or you see that on the right upper corpora there in the corner. The right corpora seems to have a balloon, an aneurysm. We don't know if the cylinder's blown out. We don't know if it's fluid, or what it turns out to be is going to be the corpora has just perforated. It's ballooned open. It's a big, wide open corporal defect that is like a large balloon and aneurysm. And we can talk about what happened and how it happened, but the first thing is we try to figure out what happened. The cylinder there, we look at the one on the left, it does not have an aneurysm to it. So he took it out, inflated it, and we were hoping, oh, that's a defective cylinder, but it wasn't. And we put a balloon dilator up and feel. Does it not go up? No, it goes up. So the dilator goes up. The cylinder came out normally. So we wonder, okay, now what's going on? Is it some intrinsic anatomic thing or maybe some fluid in there? Well, we're going to find out. We take out the left cylinder, and I'm going to show you that in a minute. First, we're still feeling around for that other side. The left cylinder had a break. Look at this, there's blood inside the cylinder. That means the left side was broken. He had fluid in the device, so it was going to break due to a fluid issue any day if it hadn't already. So it was going to stop working due to just a leak, but I think this aneurysm happened first. So I'm feeling, I'm checking. I know I've said before, this is the hardest surgery I've ever done, most difficult, and I've said it last week, but this is going to take the prize, I think, today for me. After 20 years, this is as unusual as it comes, although not made so difficult, but unusual. So the left-sided cylinder, I'm putting that in. The right cylinder, I'm going to put in, and then I'm going to test it because I'm hoping that for whatever reason, everything works out okay. Because I put in the cylinders, and for whatever reason, it was a fluke, an anomaly, but nope, pump it up. Look at that balloon. The corpora has perforated due to something. I believe he had a cystoscopy due to a stone or stent placement, and it pushed in on his penis and just perforated the corpora on the right, turned the distal aspect into a huge balloon. So the corpora goes all the way up, but around it is just a huge, wide open, cavernous space. The corpora is stretched thin, and I'm going to cut down on it. Now, he's had a circumcision sort of later in life. Maybe he's 18 years old. I'm going to cut down on it. We have to deglove the penis. We have to show that area. That's why the surgery is a little longer. And the videos too. I've got to peel down the skin to expose that part of the corpora. And the ballooning, it's huge. You can't just dissect a little bit of the corpora. We're going to have to dissect a lot of it, the whole length of the right side of his penis. The left side feels fine. But we're not done yet because what we have to do is feel it, put in the cylinder, and inflate it. And then we're going to cut down on the inflated cylinder now that we know where the whole ballooning is. And what it's going to be is a huge, like a bubble that you would make, or a balloon when you squeeze part of it. It's got a very thin wall, and it's stretched out. And clearly what you want is a tube, a tubular structure, a thin, straight tube. That's the cylinders of the penis. But up here is just a huge bubble due to a blowout, a perforation of the tunica. So we're going to cut down on it, and when we do, we open up the corpora, and it's got a thin, very weak wall, because the wall, to balloon out, it's got to have sort of a weakness to it. So we cut down. I'm sorry it's in the upper sort of part of the screen. I was kind of focused on the surgery more than the camera, but what we're going to do is open the corpora. We see that cylinder there, and we are going to put in stitches to narrow it. So we're going to do what's sort of called plicating stitches, little suspenders. So we go from the inside of one part of the balloon to the inside of the other part, and we're going to take a big circle and narrow it down to a smaller circle or cylinder. Taking a balloon and sort of reconstructing the corpora and turning it into a corporoplasty or a tunicalplasty. So what we're doing is we're going to put in 10 interrupted stitches up there, and it's going to be hard to show, but 10 stitches up there, and these stitches have a narrow base to them. So instead of going from wide to wide on that balloon, I'm going to go deep inside the balloon and go to deep inside on the other, and when I tie it, it'll effectively narrow that and have a thicker, more substantial wall to it. I considered putting a graft in to reinforce it, but grafts increase the risk of infection with prosthetics, and I don't want that. So I'm going to put the stitches in, again, just narrowing it. And you can see it's already starting to narrow. We're going to tie down all the stitches and make what was a balloon into a narrow cylinder. And we put in, like I said, about 10 of those stitches, putting edge to edge to make it narrower. So within the circle to within the circle, and we're going to do a surrogate reservoir test, and you can see the result already. What we have, when we pump it up, and the reservoir is not hooked up, but you can see back to normal. Got the normal penis shape. It's two side-by-side cylinders, as a corpus should be. As I feel like it's kind of a little irregular or lumpy bumpy. See, our fingers on the bottom where there's still a little bit of ballooning. We are going to augment what we did before by putting some plicating stitches just on the outside. So going from two areas on the outside, bringing them together, that's called a plication. That will narrow the balloon area just on the outside. The first stitches were on the inside of the tunica to narrow it. We can do some stitches on the outside to bring them together, in effect, also to narrow it. But we couldn't do that plication all the way through. You have to open the defect to close it. But a few additional stitches are placed to narrow the bulgy areas, and we're closing them down now. And you can see what happens when we tie them. It brings it together more. Now I'm ready to put everything together. I believe what we did is sound. And when we pump it up, look at that result. So there's some evidence of extra girth and puffiness, but that's the fat graft. That has nothing to do with this. His tips are now all the way up and symmetric. Before they weren't fully symmetric. And now the wideness of that upper right side is not there. It has a normal penile, long cylindrical shape to it. And we're now going to splice the tubings together and go ahead and close. So again, I'm going to show one more look at it when it's closed. And there you go. We pump it up. It looks great. I'm so happy for this man who's been through a lot in the military in his personal life. Great guy. I wanted him to have a great result, and he did. So pump's going to go back. Actually, where it was before. It's got a normal scrotum to a degree. We're going to close, and once he heals from this, we're going to close the circumcising incision as well. I think he'll be ready to cycle this in a month like any other patient would be. So tough procedure, very unusual. Andrew Kramer, Urology Associates, Cape Cod. Thank you so much.